Good morning. Welcome to the Center for Clinical Trials seminar series. We're very fortunate in our speaker this morning to have Nancy Geller, all the way from National Heart, Lung, and Blood Institute. She's been the director of the Office of Biostatistics Research at NHLBI since 1990. And there she directs and mentors a group of 12 statisticians who collaborate on the design, implementation, and monitoring and analysis of multi-center trials in the areas of heart, lung, and blood, and also sleep disorders. She administers all statistical activities for NHLBI and has been involved in the design and analysis of a number of cardiovascular trials. She served on the FDA panel, which reviewed the diabetes drug Avandia, and has published many papers in the statistical biomedical literature. She's an associate editor of Biometrics and a member of the editorial board of Clinical Trials. She's a fellow of the American Statistical Association, International Statistical Institute, and was the winner of the 2009 Janet L. Norwood Award for Outstanding Achievement by a Woman in the Statistical Sciences. She also served as the 2011 president of the American Statistical Association. So without further ado, Nancy Geller, who's going to talk to us about Till Death Do Us Part, from any cause. All right, I'm trying to get you a place for that. There you go.
This will stay here. This will be fine. Let's go around.
Can you figure it out?
Well, does this work? Yes? Somebody shake it. One of the things about giving many talks is that you learn to deal with things like microphones. So you'll now find a knot in this. It'll never come off my head, but it's fine
Is that
now.
all right?
I
feel like that. Okay.
Oh, you can. All right. Okay. So a couple of people told me they were confused by the title, and I guess that's because nobody gets married anymore in the traditional way. So, Till Death Do Us Part is, of course, part of the traditional marriage vows. And, of course, when people take wedding vows, they never think about the cause of death. But in clinical trials, we often think of the cause of death, or we maybe always think of the cause of death. And so I'm going to be talking about all-cause mortality compared with cause-specific mortality. So this was a pun on the traditional marriage vows. And the talk is not too long, and I don't mind being interrupted. So, okay. So my question is, should all-cause mortality be included in the primary endpoint of a time-to-event clinical trials? And the motivation was the early stopping of a trial that we sponsored at the National Heart, Lung, and Blood Institute called ACCORD, which appeared in the New England Journal in 2008. And I will talk a lot about ACCORD, and including some things that aren't published. And I'll talk about the effect of including all-cause mortality on the primary endpoint, in the primary endpoint, on a sample size calculation, which is just a small little example, and examine the ACCORD endpoint by treatment arm. And then I'll talk about a literature survey that Lauren did when she was a summer student at NHLBI, and to talk about what happens in practice about whether cause-specific mortality is included in the primary endpoint or all-cause mortality. And then a little bit on the effect of trial reporting and how important it is to choose your primary endpoint, which I'm sure I'm preaching to the choir here about, and some conclusions from the literature survey and the example. So the ACCORD trial was actually 3 clinical trials. The one I'll be talking about was a randomization to intensive glycemia lowering versus conventional glycemia lowering in diabetics. The ACCORD trial was all about diabetics. The 2 other trials concerned cholesterol lowering with fibrates, one, and the other blood pressure lowering. But I'm not going to talk about those. The results of the glycemia lowering trial were in the New England Journal in 2008, and there's the reference. The primary outcome of ACCORD was non-fatal MI, non-fatal stroke, and cardiovascular death. But the intervention was not anticipated to have a differential effect on all-cause mortality, yet the trial was stopped for overall mortality. And so my question was, well, should overall mortality have been included in the primary outcome of this trial?
I'm sorry, you said I can interrupt, right?
Sorry?
You said I can interrupt.
Oh, yeah, please.
So the tweet was the hope was that it would affect this composite endpoint, non-fatal MRI, non-fatal stroke, cardiovascular death.
That intensive glycemia lowering would improve.
But it would not have an effect on all-cause mortality. That means that if it were going to affect this composite endpoint, that means it would have to have a negative impact on other causes of death in order for it to wipe out all-cause mortality. Right? Because this is part of.
Well, you can have a differential effect on cardiovascular mortality and a differential effect on non-cardiovascular mortality.
I know it says here the intervention was not just have an effect on all cause mortality,
yes.
Which this composite endpoint is a component of it, right? So
no, it's not nested. The all-cause mortality includes cause-specific.
The point is that the cardiovascular mortality is expected
to improve.
Only to improve, only one-sided.
Well, that was the hypothesis. That was the hypothesis. The hypothesis was two-sided because you never know. Okay. So is that clear?
No.
Oh. So you were if you would have the same effect on non-cardiovascular mortality, then you could have a positive trial.
I understand that, but I'm just saying if you're not going to have an effect on all-cause mortality, right? But you're going to have an effect on cardiovascular mortality.
I don't think they thought that way. I don't think they thought that way.
Okay.
I mean, isn't it that they thought the effect on all-cause mortality, if it existed, would be traveling through the cardiovascular?
Right.
Okay. So
right.
And then, yes, you'd get more events with all-cause mortality, but the hazard ratio would also be attenuated, and so we may want to not include all.
Well, you're giving my talk. Thank you. Oh, sure. Okay. So a few people have written about the pros and cons of including all-cause mortality in the primary endpoint, and here are some of the pros. It happens that my division director wrote a paper in 1999 about advocating including all-cause mortality, and it's kind of ironic because now that he's director of the biggest division in the Heart Institute, he's not pushing this on us. Okay. So but the point of the paper was it's difficult to determine the cause of death, and not including all-cause death in the primary endpoint can lead to a positive conclusion, and there's no comfort in finding lower cause-specific mortality and higher overall death. And with no difference in non-cause-specific mortality, including all-cause death in the primary endpoint moves the results towards the null hypothesis. So that he was arguing that all-cause mortality should be included in the primary endpoint. A writer in Journal of the National Cancer Institute said the only reason for using disease-specific rather than all-cause mortality is to decrease the required sample size. And, of course, disease-specific death may miss important harms because of misclassification in the causes of death. And we'll see this when we look at the ACCORD data. There have been arguments against using all-cause mortality in the primary endpoint, and this one is by an intensive care setting physician. And he says treatments were rejected because they didn't decrease overall mortality, but that might have been an unrealistic goal for that treatment. And we might anticipate only cause-specific death effect rather than an overall death effect. And of course, it might increase the sample size of the trial. So let's talk about the effect on sample size calculations. So we'll assume the overall event rate is low, like in cardiovascular trials, and the effect on disease-specific death is anticipated, but not on non-disease-specific death. So, of course, including overall death will increase the sample size, and here's a little calculation. And this is ACCORD. This is real data from ACCORD. ACCORD was designed to have 89% power to detect a 15% relative reduction in the primary composite endpoint, which included cardiovascular death, but not all-cause death. And the expected rate in the primary endpoint in the control group was 2.9% a year. Per year, there was 5-year average follow-up and 3 years of accrual. And then you can calculate a 0.137 event proportion in the control group at the end of the trial. And with a 15% reduction, a 0.116 event proportion in the aggressive treatment group. And that required 10,162 patients for a two-sided test of proportions at the 5% significance level. So now let's assume there was a 2% death rate from non-cardiovascular causes in each group. So assume the assumptions were right, and that would increase the proportion of events to 0.157 in the control group and 0.136 in the treatment group, and that's just by adding to the final proportion 0.02 in each arm. And that would require 11,504 patients for a two-sided test of proportions at the 0.05 level with the same power. So that would require, for the same delta. So that would require 1,300 more patients and give you 89% power to detect a 13% relative reduction of treatment group events. And in case you're a little bit lost, here's the summary. So with 11,504 patients, there was 89% power to detect a 13% relative reduction in the active treatment group in ACCORD as designed. And with 10,162 patients, the actual number of patients, the power would decrease to 85% to detect this difference. So in fact, one has the choice of compromising the trial's power or increasing the sample size if you include all-cause mortality in the primary endpoint and don't expect a differential treatment effect. And Dan has his hand up again. Are you exercising? Are you yawning? Yeah.
So, when you, just so that I understand, in your analysis of the cardiovascular endpoint, suppose someone dies of some non-cardiovascular event, would you censor that patient at the point at which they die due to a
you should use competing risks, of course. But in ACCORD, the patient was censored, yes. I said you should use competing risks.
Are your power calculations based upon competing risks?
This is just on proportions. It's not my, the manipulated ones are my power calculations, but I did it the same way they did, which was a test of proportions of death at the end of the observed at the end of the trial. Okay, so here's what actually happened in ACCORD. This is the final graph of the monitoring for efficacy in the glycemia lowering trial. Okay, so the x-axis is amount of information observed, and the y-axis is the z-statistic, square root of the log rank statistic. And it looks sort of funny because all three trials were on one graph, and I did a lot of editing. So the arrow points to glycemia, one of the 3 trials, and it muddled around in the positive directions. These are O'Brien and Fleming boundaries. So we had, it was always above 0, and as the trial progressed, it was getting close to the upper boundary, not too close. You wouldn't get too excited over this. But this is at the end of the trial. This is, which was not the planned end. This is the last monitoring report.
Nancy, is positive meaning harm from the intervention? Or
No, it's benefit. Oh, thank you, but it's benefit. So positive is benefit here. Okay. Now, here's the monitoring for mortality. And the first thing to notice is that this didn't start at time 0. So in fact, ACCORD was not monitored for overall mortality from the get-go. And it was something that was added on after all the patients were accrued, in fact, at half the information observed. And it was not added on particularly on the basis of any observation, but rather because the statistician from NHLBI changed, became me, and I said, what, you're not monitoring overall mortality? So in fact, I wrote a 5% O'Brien and Fleming stopping rule for the trial at that point. So this is, again, O'Brien and Fleming boundaries, and the value for the z-statistic for mortality was -2 and then fell and then rose a little bit. And this was, it was based on this that the DSMB decided to stop the trial. The p-value was 0.042, nominal p-value, calculated p-value. And the DSMB said, this is not good. We're stopping the trial. We don't care what the boundaries are. I wasn't in the room when they made that decision, so I'm speculating.
But your plot was in the room.
The plot is not my plot, but the plot was in the room. Yes, the plot was in the room. And
And then what?
I wasn't in this.
no, nobody here was in the
I
room.
mean, why didn't they go back if they decided to potentially? I mean, it seems to me it wouldn't be.
To redesign and change the primary endpoint.
No, just to say, I want to go back and, we just decided we want to know all-cause mortality. Let's go figure out what people,
What happened back then? It's a good question.
If you suddenly decide you're going to collect it prospectively, it's not hard to get all-cause mortality retrospectively.
True. And I probably could ask to see that now.
It would be very interesting. I didn't even comply.
No, of course. Well, I mean, I don't think much was going on earlier on because
Nobody died?
not differentially in the 2 treatment arms, I expect.
I mean, it's hard to believe the Z-score jumped to -2,
Right. All of a
Have the
sudden,
information, right?
They weren't looking. They weren't looking. They simply weren't looking.
They weren't thinking either.
It was a bunch of, collection of pretty smart people. I think, you're saying, well, why didn't they see this earlier? And I'm standing here and saying, why didn't they wait till they crossed the boundary?
No, I'm not saying why didn't they see it earlier. I'm saying is if they suddenly decided they wanted to look at it, why didn't they go back and look at the dedication to the trial?
Yes, so, yeah, that data are available, surely.
Actually, I wasn't in the room, but I would stop this if for no other reason utility. There's no way you're going to get a win on the treatment with all-cause mortality.
Hang on. Oh. Well, I mean, we'll have something to say, about that a little bit later, where you stick some things in the primary outcome and you don't stick other things in the primary outcome, but you call them the primary adverse events. This is so you can report a positive trial. So, okay, so, you can say there's no, I think actually maybe one reason they stopped is if the primary endpoint did end up crossing the positive boundary. So if the primary outcome was positive and overall mortality was, floundering around near the boundary but not quite crossing it, I think it would be very difficult to interpret. So stopping it makes it, clear that you're saying we stop because of overall mortality, and we're not worried about the rest. Okay. So ACCORD was stopped for excess mortality, and this is from the press release, the NIH press release in June 2008, in nice, simple language. Notice they use words of 2 syllables or less. The NHLBI stopped the intensive, I was kidding, blood sugar strategy after an average of 3.5 years of treatment instead of the planned 5.6 years. Due to safety concerns, the intensive strategy group had a 22% higher death rate, or 54 more deaths compared to the standard group. So let's look at the data a little bit. Okay, this is from the last Data and Safety Monitoring Report. I probably am not supposed to show it to you. And it's at the time the trial was stopped. So all of the deaths were not adjudicated. So you've got not adjudicated yet at the bottom line, and you have cannot classify, and you have adjudicated events. Okay, and the numbers, all-cause mortality, are indeed the numbers reported in the primary results paper. So that's good. I didn't have any reconciliation to do. But you see, there are some cannot classify, there are some not adjudicated yet, and these cannot classify are a little confusing, a little bit concerning, because what do you do with them? And I tried to figure out what they did with them, but I couldn't. So, okay, so we have 131 versus 91 CVD deaths in this table, and this is the final table from the paper. So there are more deaths, more CV deaths, and in both arms, but you don't know where they came from with respect to non-adjudicated and cannot classify. And since it's so few, it's 4 more in the intensive arm and 3 more in the standard arm. My suspicion is the ones that could not be classified were not counted as cardiovascular deaths, because and that would mean they came out of the non-adjudicated. Okay. The primary is not in this table. The deaths are in this table. The primary is in this table. Okay. So this the first 3 lines of this table show the data as shown in Table 4 of the ACCORD paper. And so, being a naive, biostatistician, I added them up. And it comes to 388 in the intervention and 390 in the standard. But the primary, the Table 4 also has a number of primary endpoints given in red. So you see that there are 36 events in the intervention group and 19 events in the standard, which apparently had more than one event. And death wasn't the first one. So, there were people who had either non-fatal strokes or non-fatal MIs or both prior to cardiovascular death. Okay. So I can add on the all deaths. I calculated the non-cardiovascular deaths from the total all deaths in the table, subtracting that from the cardiovascular deaths from the all deaths. So then conclude that this includes some non-fatal strokes, some non-fatal MIs. So I guess I didn't think that this would be reported this way. I mean, I now that I know it was reported this way, I guess I don't think it's terrible or wrong, but I was really more interested in the first events. So I got, this is the unpublished data, I got the first events at the time the trial was stopped. So now I can add. Okay, so then also I could create a fantasy endpoint which included all-cause mortality. So the primary endpoint was 352 versus 371, indicating a hint that the intervention might be a little bit better. But when you go to the fantasy primary endpoint, you see they're much closer, and you wouldn't go away thinking that the standard could turn out to be better at all. So I guess my conclusion, first of all, if they had used overall mortality, maybe they never would have, in the primary endpoint, maybe they wouldn't have looked at monitoring overall mortality separately from the other two. But you wouldn't think this treatment could be beneficial to anybody if you included overall mortality. It's not a really strong conclusion. I was hoping it would do something like reverse directions, but it didn't. Right. So, and then I put it all together so you could see what happened, how many had two events. And I put the little red numbers over to the right because that's where you can add. So
I assume that.
This is the summary of the last two tables.
I assume that when this drives me a little crazy because I like to think that outcomes will be of some clinical significance. When you say a non-fatal MI or you say a non-fatal stroke, you don't bother indicating how non-fatal it was. Somebody had a stroke and then it was totally, whatever, worked out.
Vegetable-like.
Non-fatal stroke that is perfectly fine and got no aspirin and nothing else wrong.
That's right. That's correct.
There's a huge difference between.
That's correct. But, we don't often make such a distinction. Perhaps in a stroke clinical trial, you would, use some stroke scales to evaluate function afterwards. But generally, when we include, you may want to make the argument you should only use all-cause mortality as the endpoint.
Or all-cause mortality and severe morbidity or something like that.
You could make that argument, and I will come back to that and say you ain't going to do very many clinical trials, and maybe I'd rather do a few more clinical trials and get the endpoint, allow the endpoint to be a little bit softer.
I know we were all very interested when the study came out. I can't say that I paid a lot of attention to the details. That's what makes your talk so interesting. But you were talking about roughly a 10% increase in sample size to include.
I wasn't there. I have to say, I wasn't there then.
No, you're talking about it.
Yeah.
You're responsible for it.
No.
But you're only talking about 10%.
God is responsible for sample size.
It's a 10% sample size to include the most important outcome.
Right. And I asked the question why, during the trial, I asked, well, why wasn't all-cause mortality part of the primary endpoint? And the answer was, we didn't expect an effect on all-cause mortality. We thought the non-cardiovascular deaths would be just equally distributed. And by the way, going back to my power calculation, I checked the number of non-cardiovascular deaths, and 112 over 5128 is really 0.02. So I was using real data for that to demonstrate the increase of sample size. You don't often have the advantage of the retrospective scope.
You probably don't think you had the data to do it. Mm-hmm. Do you have any feel for what the hazard ratios were for your fantasy endpoint? Could it be that
I don't have that answer.
470 happened a lot faster than the 464?
I don't have that answer. I was getting data last week by begging, so. I would like to see the monitoring plot, both the one you've asked for, overall mortality from the beginning, and one on the fantasy endpoint. But I have to negotiate a deal to get that information, and probably need Cord's investigator permission if I want to write this up. So I need a little more time to get that. I really would have liked to show the graphs, but on 5 minutes notice, he wasn't. So I got these results last Saturday, to tell you the truth. Okay, so the question we worked on a couple of summers ago is what happens in the literature? Is all-cause mortality included in the primary endpoint in practice? So what we did, and Lauren did most of this, was to review 3 journals, the New England Journal, JAMA, and the Lancet, for 2 years. And it begins in July because Lauren was a summer student. So we looked at randomized controlled trials with time-to-event endpoints, such as the ACCORD endpoint, or one including overall death, and documented how all-cause mortality was reported as a part of the primary endpoint, as a secondary endpoint, or not at all. And then I did an independent check on a random sample of papers just to make sure she wasn't classifying badly. Okay. So here's some results from that. So the first line gives the number of articles in each of the 3 journals. The New England Journal publishes more randomized controlled trials than the others. And among the randomized controlled trials, the time to events, randomized controlled trials, again, the New England Journal publishes more than the sum of JAMA and the Lancet. And in those trials, among 269 overall randomized clinical trials, overall death was the sole primary endpoint in 35 of the trials. Part of the composite primary in 72 of the trials, and secondary in 65, and those are disjoint categories. So if you add that up, it doesn't come to 269. Okay. So to summarize, we broke this down into short-term trials, less than 1 year, where initially I thought that mortality would be less important, but if you have something like a surgery trial, it probably is important. So this isn't perhaps the best breakdown, but it's one we use. So in trials that were less than 1 year in duration for each patient, all-cause death was in the primary endpoint in 41% of the papers, and in the secondary endpoint in 15%, an additional 15, and was reported but not analyzed. So it said we had 3 deaths in 32%. And in 11 of the articles, of the 99 articles, or 11%, all-cause death was not reported at all. So in short-term time-to-event trials, it was all-cause mortality was included in the primary or secondary endpoint in 56% of the trials, and mentioned in an additional 32%. And I don't know why this says 12 and the previous one says 11, but 11 or 12% didn't include all-cause mortality at all.
Let me just understand this. So these are randomized trials in which mortality is an endpoint of anything?
These are time-to-event randomized trials. And the event.
Time to blindness?
Yes, would be included. And even in time to blindness, you say nobody died.
Yeah,
it's 2 words.
I'm surprised that it's reported in so many short trials that might well be related to, and you wouldn't think would have any impact whatsoever on mortality outcomes.
It depends. You can do a surgery trial where you have 30-day mortality, or infections following cardiothoracic surgery, 30-day endpoint.
Well, those are different than.
Yeah, I mean, so you could have someplace. Right.
But you could still have censoring due to death, and if you're doing time-to-event analysis.
Yeah, that's true. Well, I don't think most of them would.
We don't think most of them would die, but you could say nobody died. Yeah. I mean, 2 words
well,
that you
true.
even
nobody died.
or there were 3 deaths or something, or 2 deaths per arm. Okay, so let's look at the long-term trials. And these are trials for at least 1 year in duration. So there were 170 of those, and 66 of them, or 39%, had all-cause mortality in the primary endpoint, and another 29% had all-cause mortality in the secondary endpoint. An additional 26% reported all-cause mortality without analyzing it, and in 6% of the long-term trials, it wasn't even mentioned. So, long-term trials mostly enrolled diseased populations. 59% included all-cause mortality in the primary or secondary endpoint, and another 26% mentioned it, and 6% did not mention it at all. So, let's go back here a minute. So, basically, even though we can stand here and argue that it doesn't cost too much to include overall mortality in the primary endpoint, it doesn't look like we're doing it in practice. Okay. So this has an effect on trial reporting, and I think one reason you put your eggs in the cardiovascular mortality endpoint or the something cause-specific mortality when you think your endpoint is going to be affected that way is that you want a positive trial, and overall mortality might make the results null. So you really want a positive primary outcome in a smaller trial. It's fun to have a positive primary outcome of a clinical trial. I remember in 1999, I had one. So, I mean, I'm the curse at NHLBI. If I get involved in the trial, it's not going to be positive. That's all there is to it. So, of course, what this means is you choose cause-specific mortality in the part of the primary outcome rather than overall mortality. And it also means accentuating the positive even if there are serious adverse events. And we see that. This is a really good example. This is another one of the trials. ACCORD is one of the trials in the 2-year period, and TRITON is another. TRITON is an anticoagulation trial using a new drug, prasugrel, compared to the standard drug, clopidogrel. And this is the primary results of that trial. It was in acute coronary syndrome patients. 13,600 with 15-month follow-up, and the primary outcome was CV death, non-fatal MI, or non-fatal stroke, the same outcome as the ACCORD trial. So there were fewer primary events in the prasugrel arm with a hazard ratio of 0.81, positive trial. When all deaths were put into it, it was even more positive, so that, or it was also positive, so that you can look at the primary outcome plus all-cause deaths, and that had a hazard ratio of 0.83, and they were cheering. This was going to be the new drug that everybody was going to use. False. So it happened that there was an increase in major bleeds. So this is the repeat of the primary of the last slide with the major bleeds put in. So, so major bleed was not part of the primary outcome and was negative. And it turns out that prasugrel is not used. There are other drugs that have come out since which have a better bleeding profile. So, of course, TRITON was a positive trial, but there were an excess of bleeds. So the choice of the primary endpoint, I mean, this is not whether all-cause mortality is in it or not, but something else. But that is sometimes motivated, and perhaps more so by the pharmaceutical industry, I can say that here, right, than by others. Because you get a positive trial, then you get an indication at the FDA, and you live happily ever after, but some patients may not. Okay. So conclusions from the literature survey is that even though we've argued here and some have argued that all-cause mortality should always be included in the primary outcome of a time-to-event trial, only 40% of the trials in the literature did that. An additional 24% included all-cause mortality as a secondary endpoint, and the remaining didn't analyze all-cause death, and 10 long-term trials did not even mention all-cause death. So some have argued the first result is not surprising, that only 40% actually put all-cause mortality in the primary outcome, but at least they reported to additional substantial proportion included all-cause death as a secondary endpoint. So and the remaining trials didn't even analyze all-cause death, but the fact that long-term trials did not even mention all-cause death is really inexcusable. So I think, to summarize, whether all-cause or cause-specific mortality is the primary endpoint in a time-to-event trial will depend on the clinical entity and the anticipated treatment effect. And I use as examples infection in HIV. If you have a treatment for infection in HIV, you probably want infection-specific deaths in your endpoint rather than all-cause mortality in your endpoint. So there's a disease that's very severe, or could be very severe, and a treatment for a specific aspect of that disease. And then the intensive care unit, also argued that you may be asking too much of your treatment to have a decrease in all-cause mortality. But on the other hand, overall mortality is subjective, unbiased, and actually of primary interest to everyone. And determination of the cause of death is particularly difficult. And that's especially true when you have elderly patients with multiple diseases. So my recommendations are, in a time-to-event trial, all-cause deaths should always be reported, even if there are few or no deaths, and including all-cause mortality in the primary endpoint and the consequences of not doing so really has to be considered up front during the trial design. And if overall mortality is not included in the primary endpoint, it should be monitored during the trial and explicit in the trial report. And if you come back at me and talk about multiple testing, I'm going to shrug my shoulders. I think it's too important. That's the story. So I'm happy to take more questions.
So what are you going to do with your recommendations now? How are you going to move those forward?
Well, I don't think I'm going to make policy for NHLBI. I think, each trial will make its own decision, but if I'm in the room, I'll...
Well, I'm thinking bigger than that. I'm thinking, if you give this talk over the next year and a half, and you get
if I get to publish this talk.
then, well, more than that, you get to publish your study, you have conclusions, nobody will pay much attention to that, or maybe if you're lucky, an editorial. And then a year later, there's got to be a commentary that you have to write for another journal, and a year after that, there's an editorial you write for yet another journal.
But you have to keep saying it. Well, the discussion has been had in the past. It's not anything particularly new. I just got into it specifically because of what happened in Accord. I was there when. How do I explain this? We sit in our DSMB meetings. We're not blinded to outcome data. So I saw the outcome data, but the decision of stopping the trial was made in executive session. So nobody from NHLBI was in the room. I was there through this, even though I don't know who voted which way. I know it was not unanimous because that was openly stated, but stopping Accord. But when I'm in the discussions, I would I'd say let's consider what would happen if we included overall mortality in the primary endpoint. How much more would the sample size be increased? And Accord, I don't think had particular problems in accrual. Unusual, I realize. But, so I think it could, actually the size of Accord was 10,251, so it was slightly bigger than, I think the 89% power was 10,000, less than 200. So, it would have been a little bit bigger. And, I think probably the Accord investigators may argue that they did the right thing, doing it the way they did. I don't know.
Well, you wish they started.
So I see two hands, please.
My question is, you have a modifier over time to event trials that all-cause mortality should be included as a primary endpoint. What is your thought on other types of endpoint where, kind of event analysis is probably not a primary analysis?
Whether you should include all-cause mortality, you have to decide what you're going to do. We have these, I was involved in a kidney disease trial which had a hemodialysis trial where there was some measure of kidney function as the primary endpoint. But they decided to include deaths as part of that primary endpoint. So death was not good. It was included. You got to do something. And censoring's, you could use the time to event analysis and censor the people who died. But I think it depends on the severity of the disease, and then hemodialysis, it's pretty severe. So, if here's another example completely from the opposite end of the spectrum. If you're doing a prevention trial in a healthy population, probably nobody dies. But even if somebody does die, you have to decide what to do with them as an endpoint. And I actually usually count them as an endpoint. Death is not good. Full stop.
Very provocative talk. But I'm not quite sure that, having served on several DSMBs, including one with you, that it would have changed the outcome. I think that the DSMBs in trials like this, routinely do look at mortality. They might not have, displayed it the way you did in terms with the boundaries, but if I looked at mortality, well, this looks like it's going in the wrong direction, even if it's not part of the primary outcome. And we all know.
So we're a little. I don't know that either, but I guess until I actually looked at the data this way, I was really a little bit concerned that they stopped too early. And I will deny this if you ever say this in front of anybody else from NHLBI. But I'm really much less concerned now. There have been meta-analyses. This is peripheral, but there have been meta-analyses of glycemia-lowering trials, and Accord is different from the others. The others show a positive effect of intense glycemic lowering without an excess mortality. And in the meta-analysis, that's the result. That dominates. So Accord is different. We don't know why. I will say that it's not rosiglitazone. Dan first.
When you did your literature search, you happened to record how many of the studies censored people when they died. So if they did use all-cause mortality as a primary endpoint, did you record how many times they censored people
who died from other causes? No. But these are three respectable journals. No, you're right. You're exactly right. They probably, so if it was cancer, they probably used the competing risk analysis. If it was cardiovascular, they probably didn't. In part of this is tradition, which is not a good reason. But because in cardiovascular trials you expect people to die of cardiovascular causes. I mean, I don't know. In cancer you have, infection and toxicity, and you have these other things going on which you consider to be competing risks. But we're not right. I give you that. It's not right to not do competing risks.
If you're going to go on a platform to sort of discuss this issue,
Yeah, you need. I need another student, summer student, to go through the. And the problem with going through this whole set of trials is, another 2 years have gone by, so that we really would have to do 2 more years of literature search to get this to be really current. So, yes, Tom.
So there's a mini research project that might help here. It probably has already been done, but the technical part is easy. You're going to entertain monitoring and concluding on both all-cause mortality and the focused events that you care about. Those are correlated statistics.
Sure.
Correlated
Sure.
I suspect if you did a study of scenarios, you'd find you don't have to pay very much alpha or sample size or whatever to actually display both in a way that takes into account the association and, in some sense, buy the insurance without too much for it. Now, maybe
You know what? I don't think it has been done for monitoring specifically.
Maybe.
I don't think it has been. I mean, I got it.
It's easy, but for the scenarios you're talking about, maybe the numbers haven't been.
Well, so at each look you have a correlation, and how you adjust alpha depends on that. If you're talking about z-statistics, which we can say we are, at least for now, it's easy to calculate how you would modify alpha at that time, but that's probably not what you want to do. In general, you want to modify alpha overall. The group sequential boundary, you'd probably want to monitor the group sequential change the group sequential boundary overall, making some assumption about the correlation.
What you really want to do is to create regions in bivariate space where you say it's a win-win, it's a win, moderate, lose, and compute posterior probabilities.
I think you and I together probably have some diverse opinions, but combined insight. This is what happens when you're old friends. Yes.
One thing it strikes me we should push for is that in the consort guidelines, regardless of the trial is, we should say if anybody died. No one dies.
That was my.
You can make it nobody died. Yes. Well, I'm glad I'm giving this talk here because some of you have Kay is writing. Yes, I think that would be a good idea. Yes, it's certainly an easy enough thing to do. Yes.
This concept, and not just for the study you would discuss, but and other studies, what should be included in the primary endpoints? So if you expect that this treatment is going to affect this outcome, and may not have an effect on some other outcomes, we think it may be important to consider those. Should that be put into the sink? Because otherwise it can go up and down, and then get driven into a conclusion.
I think the anticoagulation is a good example here because you have, if you over anticoagulate, you get too much bleeding, and you can have. It may not lead to death, but it may be very serious. But generally, if the pharmaceutical industry is doing the trial, which they do many because this is a big business, they don't include bleeding in the primary endpoint. And for a while, I was walking around saying, yeah, I think you should include bleeding in the primary endpoint. But, this is one of these things where things happen at different times. I don't think I'm prescriptive on this subject. I guess, when you have a trial like Triton, you better not say we have a positive trial, this is wonderful, because it wasn't. Because of that primary adverse event. So I guess I one of the criticisms when I submitted this was that you waffle a little on the recommendations. I mean, I do. I think it's dependent on the disease and the intervention. I just think you should be very careful not to brag too much that you have a positive trial if you have some primary adverse event that's goes in the wrong direction. So, thank you all.